Eradication of a disease is a sure pathway to equity, but that's not always immediately possible. Increasing equity around the world is necessary for our societies to be successful in the long term, yet it does not occur naturally in our world. Equity must be designed and constructed intentionally to resist the inequity that happens by chance or by our own tribalism as humans. Too often we find ourselves fighting for what makes our own people more successful and neglect that which could make others successful as well. When we do this, we decrease global equity, overlooking how connected we actually are on our tiny planet and how the outcomes of others can affect our own in often unimaginable ways. Today, I'm speaking with Dr. Jim Kim, who has served as the president of the World Bank Group from 2012 to 2019, where he articulated two main goals. One, to end extreme poverty by 2030, and two, to boost shared prosperity, focusing on the bottom 40% of the population in developing countries. Dr. Kim's previous work also focused on improving public health and health education. From 2003 to 2005, he served as the director of the World Health Organization's HIV/AIDS program. In his early career, with his longtime focus on equity, he co-founded Partners in Health, a nonprofit that provides health care in the world's poorest communities. We are joined in our conversation by Dr. Kim's former colleague, Dr. Mark Rosenberg. The two collaborated when Dr. Rosenberg was president and CEO of the Task Force for Global Health from 2000 to 2016. Under Dr. Rosenberg's leadership, the task force grew to be one of the largest nonprofit organizations in the country and instrumental in providing people in the developing world with greater access to vaccines for influenza, cholera, and other deadly diseases, and medicines for multidrug-resistant tuberculosis. Thank you both for joining me. Dr. Kim, I know you have a long career of equity building. What's a great example of global health equity in action from your work?
I'll never forget an early meeting with Bill Foege when he had just moved to the Gates Foundation. And Bill Foege said that the goal of the Gates Foundation was going to be global health equity, which was an astounding notion that the richest man in the world at the time was going to focus his enormous wealth on an idea that we at Partners in Health had found so powerful and so important, the notion of equity. At Partners in Health, we had a language for it. We called it option for the poor, but it was really the same idea. It was the notion that as healthcare practitioners, as people involved in providing healthcare services, that we had to get to a place where we could say that even the poorest people in the poorest countries and the poorest villages of the poorest countries would get access to the kind of care that we want to provide to our family members or to our patients in the very advanced Western medical centers that we were working in at the time.
And these earliest ideas of yours, Jim, and ideas of your colleagues at Partners in Health, they were really breakthrough thinking at the time, sort of the foundations, the vision for global health equity.
Well, what we found was that if you're starting from a position of wanting to move toward global health equity, then you have to ask a different set of questions. So for example, Mark, when we discovered really an outbreak of multidrug-resistant tuberculosis in a shanty town in the northern part of Lima, we found 50 cases in a town of 100,000 people, which is just, if you found that in any developed country, an advanced economy, the public health people would go crazy because drug-resistant TB is extremely difficult to treat. It's deadly. It can kill people, and also it's an airborne disease like COVID. In other words, if you're in close contact with somebody with this disease, you could catch it, and you could die.
This was really serious.
We thought, this is crazy, 50 cases, what are we going to do? And we went to the World Health Organization, and they said, well, in poor communities, multidrug-resistant tuberculosis is untreatable. You can't do it.
And that response did not sit well with you, did it?
Well, our commitment to global health equity, our commitment to this notion of an option for the poor, wouldn't allow us to walk away. And so we started treating the patients. And at first, the drugs were really expensive. They were really hard to get. And we were really fighting the entire global health tuberculosis community. They kept saying, this is crazy, don't do it, it's too expensive. But we kept saying, but you're seeing outbreaks in families, in communities. We can't just walk away. This could take over other cases of tuberculosis if we don't fight it here.
Sounds like most of your contemporaries didn't understand, couldn't justify the expenses of treating these cases in a poor region of the world.
We started off fundamentally in disagreement with the global health community. And luckily, when Bill was at the Gates Foundation with this notion of global health equity, he gave us a $45 million grant that we worked on with you, Mark, in the task force at the time, to try to come up with models and an approach to doing all the things that you need to do in order to treat multidrug-resistant TB effectively. And it got right to the most fundamental, if you will, management issues, very specific things about delivery that can ensure that these patients will be cured at a high rate, we won't create further resistance, and we can really tackle drug-resistant TB at a high level.
And this idea of yours, Jim, yours and Paul's and the other folks at Partners in Health, that you could bring care to Caraballo, a tiny little suburb of Lima, Peru, that was as good as they could deliver at the Harvard teaching hospitals. This was a breakthrough in thinking. It was kind of the beginnings, the foundation of global health equity.
Amazing. Thank you both so much. For Dr. Kim, Dr. Faggy, Dr. Rosenberg, and Partners in Health, by starting with global health equity as a given, a commitment upfront, the fact that treating MDR-TB in poor countries would be expensive or difficult became in many ways incidental. Of course, it was hard work, but by starting from the absolute recognition that equity in health came first, lives were saved and potential global outbreaks were prevented. Every nation benefits from health equity.